all doctors need to
Hmm.
know how to examine this tissue because it matters for your bladder health, your pelvic floor health, your vaginal health,
Yeah.
your sexual health. It just matters.
Dr. Maria Uloko is a board-certified urologist specializing in sexual health, reconstruction, and prosthetics, recognized globally for her expertise in treating sexual dysfunction across all genders. As the CEO of MUMD Sexual Medicine Consulting and founder of VULVAi, an AI-driven patient advocacy tool, Dr. Uloko is committed to improving the quality of life for her patients through compassionate and inclusive care. With extensive experience in conditions like vulvar sexual function, erectile dysfunction, and hormone replacement therapy, she also focuses on addressing healthcare disparities and advancing medical education. A respected researcher and former UCSD professor, her work has been featured in leading publications such as the New York Times and Forbes. Thank you so much for joining me today to answer the questions from our community.
Thank you so much for having me. I'm so excited to be here.
Well, it would be amazing if, first of all, you could share more about your professional background and your current research.
Yeah. So I am a board certified urologist that specializes in comprehensive sexual health, which means that I take care of the medical and surgical management of sexual dysfunction of all genders. There are about seven of us that are fellowship trained to do this in the world. And it is so fun. So everything from menopause to chronic pelvic pain to erectile dysfunction, I get to be able to support people throughout their lifespan and throughout their sexual health journey. So it ranges from disease to pleasure, and that's I get to be with people through that. And then in terms of my research has been focusing on really filling in the gaps in knowledge, which sounds like that's what
Mm-hmm.
research is, but if we really think about that's like you're like, well, duh. But in women's health, actually, there's a lot of foundational research that still hasn't been done
Mm-hmm.
yet. So our research group is mapping out the vulva. So we won two international awards for discovering how many nerves are in the human clitoris. We're currently mapping out the hormonal pattern of the vulvar vestibule now. I do a lot of research as well related to vulvar health and disease states, and as well as disparities, care, education reform. A lot of doctors aren't being trained
Mm-hmm.
on this, and bringing that awareness to physicians and to the healthcare world, and also to patients, because that's really who I do all of this work for. Is that I think of research as a means for advocacy. It's a
Mm-hmm.
means to create access and to answer really tough questions
Yeah.
with the idea that all of that answering a question is ultimately going to lead to solutions that are going to better people's lives, and help them live healthier.
That's really well aligned with the work that we do in research and advocacy as well. And as a community of people living with recurrent and chronic urinary tract infection, we get a lot of questions about chronic vulvar pain. And so it would be great to start there. The first set of questions is about terminology. So if you could explain how the terms vaginismus, vestibulodynia, vulvodynia, and the overarching genitopelvic pain penetration disorder are defined, that would be a helpful place to start.
Yeah, this is actually such an interesting question because it goes to show just even within the field of medicine, how we call kind of the same things
Hmm.
different words. And so words really matter when you're coming in with conditions that are considered hard to treat.
Hmm.
And I think this speaks more to the larger narrative of kind of that lack of accuracy in when it comes to vulvar health. So let's get real clear about this. So
Yeah.
vaginismus is a term that actually just means vaginismus, is a psychological fear associated with penetration. And so that psychological fear oftentimes leads to muscle tensing. So many people will use a lot of these terms interchangeably, but they actually mean different things.
Hmm.
Vestibulodynia, so vulvodynia is essentially vulva means all of the vulva, and then dynia means pain. So pain in the vulva. It's a very general term of like, I
Hmm.
don't know, something down there is painful, which again, you can kind of see kind of the lack of care
Yeah.
in that terminology. Vestibulodynia is a subset of vulvodynia So the vulvar vestibule is a structure that most people actually think is the vagina, but the vagina is the canal on the inside. You don't see the vagina, but most people, when they think of their vagina, they're actually thinking about their vulvar vestibule. The vulvar vestibule is such an interesting, it's like my research baby. I'm obsessed with this tissue structure because it's actually bladder tissue on the outside of the body. And also, it's very testosterone dependent. And the vulvar vestibule, vestibule literally means entrance to the temple. So it is the entrance before you get into the vagina.
Hmm.
And the vestibule is actually the site of 90% of vulvodynia. So vestibule, dynia, pain in the vestibule. So this is why like words matter because like
Hmm.
if you just say vulvodynia and you're like, okay, what that could be clitoridynia, that could be labiadynia, it could be
Yeah.
pain anywhere. Versus when you start getting really granular and you say, I have vestibulodynia, you have pain in your vestibule, and then it helps to start breaking those things down. And then GPPPD is the terminology coined by the DSM-5, which describes 6 months of pain with penetration, anxiety and fear with penetration. And
Hmm.
so it's more almost like a psychological terminology, as seeing that it's in the DSM-5
Hmm.
than like vestibulodynia or vulvodynia. So GPPPD is kind of like the big umbrella terminology of when you have penetration or any sort of sexual contact, you're going to have pain. And vulvodynia is the most common type. Vestibulodynia is the most common type of vulvodynia. And then vaginismus is the mental anguish
Hmm.
that is result from all of the pain. So
Right.
they're all interconnected,
Yeah.
but it's really important that you use the correct terminology. But for the most part, most people don't know that. They just
Yeah.
say it hurts, and so they use it interchangeably.
Yeah, and that's what's going to be my next question is that people often do feel pain from many different sources when they have chronic bladder infection and then they have these other pains in the vulvar region. So they might not know how to differentiate that pain. How does a clinician diagnose between these different types of pain?
Oh, very poorly. I'm not going to lie to you. So, and the reason for that is because most clinicians aren't taught about the vulva. So,
Hmm.
I started medical school at 17, and so I have now been in medicine for 15 years. It was like truly wasn't until my fellowship in 2020 4 years ago where I learned about the vulva,
Hmm.
which is fascinating because part of the vulva is the bladder. Like we said, the vulvar vestibule is bladder tissue on the outside of the body. So for a lot of people suffering with vulvodynia and vulvar pain, they actually have, I think it's about the stat is like almost 65% that people with vulvodynia will also have urinary symptoms too.
Hmm.
So urinary symptoms, classic urinary symptoms are classic symptoms of a UTI of urgency, frequency, pain with urination, burning with urination. You can even have some blood and even some lower abdominal cramping. So there's a lot of overlap
Hmm.
between UTIs and then also vulvar health because in I'm going to I'm going to change the paradigm, or I'm going to
Hmm.
change the paradigm of how we think about what we're calling UTIs. I want to start calling these symptoms lower urinary tract symptoms because pain with urination, burning with urination,
Hmm.
um, frequency, urgency, incomplete emptying, those aren't those aren't only synonymous with a UTI. It can be so many other things. And so even the way that, when people start having these symptoms, they immediately go to their doctor and they say, I have a UTI. What you actually have is lower urinary tract symptoms. And what should then happen is that the doctor should then do a formal evaluation of not only your urinary system, but also of your vulva to
Hmm.
actually see what is attributing to your symptoms. So that is the paradigm that I'm actually trying, and a lot of my research has discovered this, and I'm trying to now get into the broader narrative of healthcare and training.
Is there an understanding of how a diagnosed UTI could lead to chronic vulvar pain?
Yeah. So, I I again believe that we need to push, like take a step back. So when a person is coming in with the symptoms, the classic symptoms of what we've deemed UTIs,
Hmm.
we have to start thinking about this is an inflammatory state. It could
Yeah.
be inflammation from an infection. It could be inflammation from hormonal changes to the vulva. It could be an inflammation from vaginal infections. There's it can be inflammation from really tight pelvic floor muscles.
Hmm.
You know, there's so many things that can mimic a UTI. And I actually am starting to want to challenge physicians to start thinking broader when a patient is coming to them with these classic symptoms that we've always attributed to infections. So ultimately, all of these symptoms can cause inflammation. Whenever you have inflammation, either if it's in the urinary tract or of the vagina, they're right on top of each
Hmm.
other. They're the same tissue structure. And so that inflammation can then translate into vulvar pain as well. And so that's how the that can go into vulvar pain. The other thing is that you can also get secondary pelvic floor dysfunction.
Hmm.
So the first thing that happens when your body is in pain, it's not uncommon for it to tense up.
Hmm.
And so and I use the analogy of like, let's say that someone's going to throw a punch at you. The first thing your body's immediately going to do is tense up to protect itself. That is what your pelvic floor does when it's having inflammation happening. Some people, they're able to think about it and relax their pelvic floor. But for a lot of people, we store a lot of tension and pain and discomfort in our pelvis. That tightening of the muscle without us really thinking then exacerbates the pain that we already feel and exacerbate the inflammation. So it's a kind of never-ending loop. You cannot think about the bladder without thinking about the vulva, and that's really what my research is showing. And it's really, really, really exciting
Hmm.
to rethink the paradigm of diagnosis around chronic UTIs because I'm a big believer that most people actually don't have chronic UTIs. I think they just are misdiagnosed because most doctors don't know about the vulva.
Yeah, I think there's a lot of misdiagnosis and underdiagnosis in this space in general. And we often hear from people who just haven't been able to get diagnosed with anything. So it's not a case of misdiagnosis, it's just a lack of diagnosis. But
Yeah.
previously, you mentioned the psychological impact or the link of psychological effects. How influential do you think that is with past trauma, anxiety, and chronic vulvar pain?
Oh my gosh, it's so impactful. But the thing is, it's not. it's not the oftentimes the driving cause of their pain. It's just an exacerbating factor of the pain.
Hmm.
And a very common cycle is that, a person with vulvar pain will come in, they say, hey, I've been having these issues, then the doctor will dismiss them or guess and put them in this never-ending cycle of misdiagnosis, trial and error. So on average, it takes about 7 years to get your first correct diagnosis.
Hmm.
Like that's 7 years of advocating, that's 7 years of pushing, that's 7 years of suffering
Yeah.
and that worsening of I go to the doctor, I'm looking for answers. I want to get better. The doctor's telling me there's no way to ever treat you. You're never going to get better. Psychologically, that is
Hmm.
so damaging. If you believe that your disease is never going to get better, it totally changes your disease, your outcome around and the attitude around um, what you are experiencing versus it's not uncommon for people to come to me. They've been struggling for decades, and I'm like, I can diagnose you in 30 minutes. I know exactly what you have based off of my training and my research and my expertise. And you can literally watch their hope come back.
Hmm.
It is one of the coolest things to give people back their hope
Yeah.
and then to actually then solve their problem. Like I've had so many patients how I came into the UTI space is that a lot of people after sex will have UTIs. I've
Hmm.
had so many patients and I'm also a urologist. So I started in the UTI space, but then I broadened my UTI
Yeah.
research. So many people that wouldn't have sex, couldn't have kids, could never do the
Yeah.
thing because they were so afraid of the potential of a UTI, the potential of pain, all of the things.
Hmm.
And I've gotten so many ultrasounds of babies of like, hey, I'm pregnant. Like that is the best feeling.
Yeah.
Or I haven't been to the ER in 6 months. Like that to me is just the absolute best feeling in the entire world to be able to give people their life back. And you just get to see that psychological change of you're not broken. This isn't chronic. A lot of this is just misdiagnosed,
Hmm.
and we can get down to the bottom of things. So yeah, the psychology around how we even talk about these disease states really, really matter.
Yeah, I agree. And can you talk a bit about how you get down to the bottom of things for someone who has had this kind of pain for such a long time?
Yeah, okay. So really it's just knowing the vulva. That is the tea. That is really my secret sauce is understanding that vulvar anatomy and physiology is very linked to bladder anatomy and physiology. And so when someone comes in with symptoms, I just have a larger toolbox and toolkit for figuring things out. And how I came out about this was when I built the first vulvar sexual health clinic run by a urologist in the United States that openly
Hmm.
accepted insurance. And I had a significant volume. It's interesting when I proposed this idea, everyone was like, I don't think women will want this. I don't think people will want this. And then I had 2,000 patients in 2 years and a year and a half waiting list. I was like,
Yeah.
I think people definitely want this.
Hmm.
But, as a trade-off, I then inherited the UTI clinic. The prior physician was well renowned, world renowned in her work in UTIs. And so it felt like I was stepping into really big shoes. And so I was taking over her patient and building a vulvar clinic. And, a lot of my vulvar clinic was a lot of pain. And then I would go to my UTI clinic and I was hearing the exact same
Hmm.
symptoms: urgency, frequency, pain with urination, burning. Also, sometimes it hurts to have sex. Like, oh, I'm getting UTIs after sex. Like, I was like, wait a sec, all of you guys are exactly the same.
Yeah.
Fascinating. So then what I did was I did a protocol where the American Urologic Association has guidelines about how to manage a chronic UTI patient, or like how to work them up. Of like, okay, when someone comes to a urologist for recurrent UTIs, our job is to figure out, is there something in your anatomy that's causing this? And I think about being a urologist just means I'm a glorified plumber, right? I just got to
Yeah.
make sure that the pipes are flowing well. If the pipes aren't flowing well, that's how I think about the urinary system. I just got to make sure all the things it's good with the plumbing. And one thing that the guidelines absolutely forget is that the vulva is part of the plumbing. It's actually the end part of the plumbing. The urethra, which is the hole that you pee out of, sits right in the vulva. And like we said, that vestibular tissue is bladder tissue on the
Hmm.
outside of the body. So I did this protocol where I did the AUA guidelines, but then I added in my vulvar training and how I work up my vulvar patients. And so in a 2-year cohort of roughly about 350 patients that were referred to my clinic for recurrent UTIs, I found that 88% of them actually had an inflammatory hormonal issue
Hmm.
and not an actual infectious inflammatory issue. So 88% of the people that had been told their entire lives, or however long
Hmm.
this issue had been, of you have recurrent infections and disease, actually had an hormonal issue that was causing and mimicking the same symptoms and predisposing them to UTIs. And we treated the vulvar inflammation and we absolutely stopped their UTIs. 88%. So that was over 2 years.
Hmm.
When the final results of that came out, I was like, this is wild. This is
Yeah.
this
It's
is
significant.
groundbreaking work. Also, 88% of misdiagnosis, that's actually like that's clinical error at that
Yeah.
point. Like we're doing something wrong. So then we did a database study to confirm this because I was just like, there's just no way. Like there's no way that we've just been doing this wrong this entire time. And turns out we have been. So we actually then looked at so this inflammatory condition, this vulvar inflammatory condition, is directly related to your hormone status. And
Hmm.
so and there are many medications that change your hormone status, particularly actually testosterone. Testosterone is a very important hormone that is produced by the ovaries, and it's very important for your vulvar vestibule to stay and remain healthy. It needs estrogen, and also it needs testosterone. The vulva is actually a really testosterone driven organ. So then we looked at the rate of we did a database study, a national database study, and looked at people that had been prescribed anti-androgen medications. And so that could be oral contraception, that could be acne medications, hair loss
Mm-hmm.
medications. Um, we looked at, if you've been prescribed anti-androgen medications, which causes a vulvar inflammatory state, versus the general population, did you have a higher rate of UTIs? And yes, they did. And so both of those research projects have both been presented at the AUA, at Sexual Medicine Society,
Mm-hmm.
like all throughout the world, and um, we're finalizing the papers now. But yeah, I mean, this is huge. This is a game changer for patients that have been suffering and been told that they're chronic diseases, when in actuality, it's just high rates of misdiagnosis.
Mm-hmm.
Because unfortunately, most doctors don't know about the vulva. We actually just recently did a research study that showed 75% of doctors don't that are currently undergoing medical training today. That's all across all specialties,
Mm-hmm.
including gynecologists. Gynecologists are actually the worst
Okay.
reporters of knowledge around this. Don't even know about how to examine the vulva, vulvar diseases, and then how to treat vulvar diseases. And these diseases are very common. They actually affect 100% of people because they're related to hormones. And
Mm-hmm.
everyone, if they live long enough, is going to go through menopause. So there's a real reason as to why menopausal people get UTIs. It's 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 all, you see how it's
Mm-hmm.
all connected. And yet we've been missing this because we don't understand hormones, and women. We're not taught as a medical community about
Yeah.
hormones in women, about testosterone in women and the vulva, and about vulvar anatomy and physiology. And that's actually why I built the company that I'm building.
Did you find in that the 88% of people that that was the same across all age groups, or is that mostly perimenopause and postmenopause?
It was the same across age groups. So in the premenopausal patients, I always get labs.
Mm-hmm.
I always check their testosterone. I get a full comprehensive panel, hormone panel. As a researcher and as a hormone specialist and vulvar specialist, I understand intimately that the vulva is dependent on your hormones. If your hormones aren't healthy, your vulva isn't healthy.
Mm-hmm.
And so all of them actually had significantly low testosterone
Mm-hmm.
levels in the premenopausal people. And then in menopausal patients or postmenopausal patients, I don't check hormones. Unless they're coming for specifically for hormone replacement therapy and menopause management. But if they're coming for UTIs, I typically don't check their hormones because I already know that their hormone status is low, because that's the whole part of menopause, is
Right.
that your ovarian reserve of hormone production is practically zero for estrogen, is at zero for estrogen and progesterone, and then for testosterone significantly lower. You still make a little bit of testosterone in your adrenal glands, which are like
Mm-hmm.
little nuggets that sit right above the kidneys, but very markedly low states. And so that's why we see it's a huge contributing factor as to why so many people will develop quote unquote UTIs.
Yeah.
Um, yeah.
Aside from hormones, are there other things that you've seen commonly in people that are causing the vulvar pain?
So the most common is hormones. That's the
Mm-hmm.
one I see the most. Because it is it's so ubiquitous, right? So many people are on oral contraception. So many people are experiencing menopause and unsupported through their menopause
Mm-hmm.
journey. The second most common cause of these symptoms is pelvic floor dysfunction. So
Mm-hmm.
we'll see a lot of pelvic floor dysfunction mimicking your lower urinary tract symptoms. And oftentimes pelvic floor dysfunction is a is it's plus something else, right? It's oftentimes, it's like we talked about, it's the body's natural response to pain and stimuli is to tense up.
Mm-hmm.
And so pelvic floor dysfunction then worsens the symptoms. Other things that it could be is nerve issues. So you can
Mm-hmm.
have no, local nerve, like too many nerves in the vulvar vestibule. There's actually something called neuroproliferative vestibulodynia, where inflammatory something inflammatory happened. You get an inflammatory response, and then that leads to new nerve growth in a tissue that didn't really necessarily have all these nerves. And so
Mm-hmm.
all of a sudden you can just feel your vestibule all the time. Then there's also something called pudendal neuralgia, which is inflammation of the pudendal nerve, which is the nerve that innervates the external genitalia. So, and then you can also have almost what we call genitopelvic dysesthesia, which is sciatica of the pelvis. So, sciatica is you have leg pain, but it's not actually coming from your leg, it's coming from your spine.
Mm-hmm.
Very much like you can have sciatica in your legs, you can also have sciatica in your pelvis because it's all the same nerves.
Right.
So if you have a back pain and back issues, they can't figure something out, I always tell people to check the spine because it can very much like you can have pain in your legs, you can also have
Mm-hmm.
pain in your genitals that are related to the nerves in your spine.
How would you differentiate between nerve involvement or a pelvic floor issue?
Yeah, so it's knowing how to do an exam. It's knowing how to do a comprehensive vulvar exam, which most physicians are leaving training not
Mm-hmm.
knowing. And like I said, I'm one of seven in the world that was trained on how to do this. And we've trained about 300 or so doctors, and we keep training and we keep advocating for more and more. But this is going to need widespread reform. All doctors need to
Mm-hmm.
know how to examine this tissue because it matters for your bladder health, your pelvic floor health, your vaginal health,
Yeah.
your sexual health. It just matters. And so it's a really a disservice that we're doing to patients that we are training doctors not to, and their doctors are leaving training without learning this. Yeah, I'm on a mission to train
Mm-hmm.
every single doctor around the world. I'm on a mission to train every single person with a vulva how to do their own exams and
Mm-hmm.
how to advocate for themselves in the doctor's office.
But speaking of clinicians, what type of clinician would be the right one to see for these types of conditions?
Ugh. If you want the level of care that you deserve, come see me.
Mm-hmm.
So in theory, traditionally, it's a urologist or you're a gynecologist. But again, like I said, in our current guidelines that exist, we don't have much structure around how to do a vulvar exam. And so that's that's unfortunately such a big disservice to
Mm-hmm.
patients. And that is what VULVAi is wanting to do. We're trying to mass train physicians
Mm-hmm.
on vulvar anatomy and physiology and real-time training on site, because every doctor should know how to do this, but every doctor is leaving training without knowing how to do
Mm-hmm.
this. So how do you then fill in the gaps where doctors are failing? And how do you then train an entire generation of physicians in real
Yeah.
time? That's where technology is going to come into play, and that's what we're building and working with some really cool institutions to implement this program and
Amazing.
start the process of mass education.
Mm-hmm. And what about on the patient side? Are there resources that you have for patients to kind of tackle this on their own until they have a clinician who can help?
Yeah, that's why I'm also working on it. I'm trying to figure that out. We do also have, and when I think about the urinary system, there's so many things along the pathway that it could be. So if you're someone that you should absolutely still go see a urologist. They know the top of the like they know the top all the way to the bottom. They oftentimes just don't know the vulvar piece, which is such an important
Mm-hmm.
piece. But there's still so many things that could be outside of the vulva that could cause some urinary tract. So I don't want that to deter people from going to see their urologist. I
Yeah.
just also want them to understand that their urologist typically doesn't have the vulvar training, but we're actually, as a group collectively, we're way more progressive than a lot of other fields. So I actually see us changing our guidelines, hopefully in the next several years, to
Mm-hmm.
start doing this. And a lot of the people that have such buy-in already are urologists. They're like, oh, I need to care about this. Oh my gosh, now there's new research. Oh, now we adopt technology and we adopt new research much quicker than other specialties. So I have hope. I have a lot of
Mm-hmm.
hope. So that, and then two, Vulva AI, what we're trying to do is we're trying to do two things. We're trying to teach doctors in real time, and then I want to be able to arm patients with the right information on and how to advocate for yourself. So if you go to an institution that doesn't have Vulva AI and doesn't have their physicians trained on it, and utilizing the technology, you don't have to still suffer. You
Mm-hmm.
can still get all the information. I can teach you how to advocate for yourself. Like what we're trying to do is teach you how to advocate for yourself, how to ask the doctor for, I want this lab work. I want this,
Mm-hmm.
imaging study. I looked at my vulva. I actually touched it and it hurts.
Yeah.
I did my own exam and this is the treatment. And please write for it. And that there is a conversation, there's a dance here, and patients don't understand how powerful that they are. Um, and yeah, you'll meet some like jerk of a doctor, that doesn't believe you,
Yeah.
and that's unfortunate. I will not um it sucks. It sucks. It sucks. It sucks. It breaks my heart when that happens and I hear that. And I know our immediate is just like, just go find another doctor. But like, no,
Yeah.
it's hard. It's
It
really
really
hard and
is.
really tough. It's so demoralizing.
Mm-hmm.
Um, and so I want that's those experiences, I've sat with thousands of patients and I've heard their stories of neglect, of misdiagnosis, of essentially malpractice. And I
Mm-hmm.
was like, I have to figure out a way to protect these people. Like it just sucks. And when I think about my experience with healthcare and like growing up without it, being a Black woman in the healthcare system, and
Mm-hmm.
knowing the barriers that I face, even with all the privilege and education and resources that I have, I wanted to build something that makes sure that when you are going into the doctor's office, you are as informed about your body, about the research, about the science that's out there, because most doctors aren't staying up to date on that. They're not doing those things. And it shouldn't be the patient's fault that the doctors don't know. You should still be able to figure these things out because the treatments are, for the most part, if it's related to just vulvar inflammation, are so straightforward and so easy, but just no one knows to look or check or what to check for or what these conditions are called. So
Yeah.
yeah, we're gonna make sure everyone's gonna get diagnosed.
Yeah.
Cheap, fast, easier. Like we gotta do better.
It sounds kind of ideal. And patients do end up feeling quite helpless in these situations because they don't feel like they should be responsible for navigating their own health in that way. But it really does
Abs-
come down to that. They need to advocate for themselves and to learn as much as they can.
Yeah, yeah, and it's such an unfortunate system, and
Hmm.
I sit with so many people, and I hold space, and we cry together, we grieve together. I get to watch their pain and have the privilege to kind of hold them in that space, and
Hmm.
I can't change the entire system, but I can change how people are interacting with the system. This is like the little piece that I know.
Hmm.
This is the hill I'm going to die on, that people should not be suffering. People should, like, a lot of what we're calling chronic diseases aren't chronic. They're just misdiagnosed. And that is why I was hit by a car 3 days ago, somehow
Wow.
survived at 30 miles per hour, and then immediately got back to work because this is the work that I love
Hmm.
to do. This is like the ability to teach and train and give people hope back just with education and knowledge is like it. I feel so aligned in everything that I do, my research, my work, my passion. Like I love this work. It's tough, it's challenging. Oh my
Yeah.
God. I wouldn't, it's not for the faint of heart, but to be able to give people hope again and like cure them of diseases that they've been told are incurable
Yeah.
is one of the best feelings ever.
Yeah, and I want to talk a little bit about the impact on quality of life with some of these conditions. Can you share some insights about how they do impact sexual function and just quality of life in general?
Ugh. When people are in the UTI cycle, it is just so debilitating. It it
Hmm.
it, it fully shuts down every part of their life, and to the point that a lot of people just aren't even functional anymore. It consumes their every waking moment. Like, not
Yeah.
only are you suffering of like having that discomfort consistently over and over again, you then don't have the answers to why it's happening.
Mm.
You then don't have the answers to when it's going to happen again. Like they are living in such fear and paralysis, and they keep go to the doctor who they're supposed to trust, who's supposed to have all the answers, and they just can't get answers.
Yeah.
And in actuality, their doctor only has a very small toolkit, and the doctor needs a much larger toolkit to actually assess these patients. And that's why I'm so vocal about this, because so many people start internalizing the medical system's ignorance as
Mm-hmm.
I'm broken, something's deeply wrong with me, I'll never get better. And then those are the patients that are then dropped off at my doorstep. And I'm like, oh my God, we have
Yeah.
so much to unpack. Like, I recently just had a patient where it took 2.5 hours just to get all of the history.
Mm-hmm.
And that, I was like, I, I haven't even, I can't even do an exam. Like, I don't have, like, that's what I built my practice to be able to give patients time.
Mm-hmm.
But 2.5 hours to explain your medical history is just so devastating. Like,
Yeah.
so many feelings and so many emotions, and it's so hard to see that when all she really needed was a vulvar exam. Like, if she had gone to a doctor that knew, gotten a vulvar exam, started on treatment, she would have been great back to her life. But because of 5 years of trial and error and going to doctors that don't know and all the things, I now have to spend five unpacking all of that,
Mm-hmm.
undoing all the trauma related to that, and then getting to treatment. And it's so tough. It's really, really tough. Yeah. So if I can prevent anyone from going down that spiral, that happens, that I've made a big difference.
Yeah, and patients articulate these compounded issues really well too. And someone wrote in a question about having a low libido or an absence of sexual desire, but also bladder symptoms, insecurity, anxiety about UTIs, hormonal changes affecting physical comfort, and pain during sex. And asked whether, with all those issues put together, it is possible to move forward, and whether you've had patients who've been in a situation like that and got to a point where they actually enjoyed sex again.
Yeah, so many times. So many times. That's actually like my bread and butter, is post-sex UTIs. It's not a thing. It is, it's absolutely not a thing. And who does research matters. A lot of the old researchers and a lot of who teaches us are old men without vulvas. And so of course, and then also culture and society, and in Western society, female sexuality is considered unclean and like gross. And
Mm-hmm.
so it then translates to, well, you're getting UTIs after sex. Of course, that's gross. That's disgusting. And like,
Yeah.
I want to tell people, unless someone is pooping into your vagina, the vagina is meant for wear and tear. It has a whole ecosystem that is like, it is one of the most resilient structures ever. And the fact that we have gaslit an entire generation of people with vulvas to believe that having sex is going to lead to infection every time is it's a symptom of the patriarchy. Like that's what it is. So instead of actually going into the science, they just said, you're just a lady. You shouldn't be having
Yeah, we
sex
hear
and
that a
enjoying
lot.
yourself, right? Like I have like essentially post-coital, post-sex UTIs are not a real thing. We should not be accepting that as um, a diagnosis. It's not. It's oftentimes the hormonal inflammation. It's oftentimes pelvic floor dysfunction. There's oftentimes so many other things. And yeah, once in a while you can get a UTI after sex, all the like totally fine. But if you're having sex and every time you're having sex you're getting a UTI or it's happening more than twice a year, please reach out. Like that's
Can
not normal.
can you talk
And we
about some of the ways you would approach that? Because there are a lot of people in this community who do have that experience. That's why they're afraid to have sex, because they have this problem. And then you mentioned earlier about people not being able to get pregnant because they can't have sex. That also happens a lot in our community. So any kind of approaches
yeah,
that you can talk about would be helpful.
yeah. So I'm going to tell an anecdote that is so powerful for me. There was an OB-GYN resident that booked an emergent appointment with me on a weekend, and she told me she's an OB-GYN. She is a gynecologist. You think they would know this stuff, but this is why this is really important.
Mm-hmm.
So she newly married, never had sex prior to marriage. And then for the first year and a half, could never have sex. Every attempt would lead to a UTI. And so unable to, have that shared intimacy with her partner, unable to fulfill the dream that she had of wanting to be a mother, also missing work. She's a resident. I
Mm-hmm.
mean, if you've ever met an OB-GYN resident, they're delivering 9 babies at a time somehow. And you're like, how is this possible? They're constantly working. And she's now suffering. And she's trying to take care of other people and can't even take care of herself. And so, just in this, it was a virtual consultation. And in that conversation, I just was like, have you taken OCPs? Like, I almost to the point, like, I can already like ask this question. Have you taken OCPs? She goes through her whole history, and obviously I'm listening and I'm sitting and I'm holding space. But I just always am like, have you taken OCPs? And she said, yeah, I took it for 3 months. And then I was like, okay, I know exactly what you have. So a lot of post-sex UTIs are actually because of vulvar vestibular inflammation.
Mm-hmm.
So again, the vestibule um, is bladder tissue on the outside of the body. The vestibule is also the entrance into the vagina.
Mm-hmm.
So for a lot of people, oral contraception, menopause, anything that's going to change your hormones and going to disrupt your testosterone is then going to cause chronic inflammation.
Mm-hmm.
So think about it like you are actively sitting on sunburned skin. For some people, that sunburn is so severe that even just sitting on it is painful. For some people, that sunburn is mild and they don't necessarily notice it. And also the hilarious thing about treating the different sexes is that pain tolerance is crazy between the two sexes.
Mm-hmm.
Like people with vulvas are like they're rating their pain at like a 10 and they're like, yeah, no, I'm totally fine. I was like, no, you shouldn't be suffering. That's like, and I'll have, my penile patients, they're like, I'm at a 2 and I'm dying. And I'm like,
Yeah.
very different pain tolerances it's very fascinating. That's why I love being able to treat all of the spectrum because I get to actually see how culture and society and all these things impact how people present in my office. And so, so many people will just like accept that, yeah, it's like a little itchy and all the things all the time, but it's not that big
Yeah.
of a deal. And then when you have sex, penetrative sex, or any sort of friction to the tissue, you're now actively touching a sunburn.
Yeah.
So, depending on the degree of the sunburn, like if you had a very severe sunburn, aka severe inflammation, it's going to feel like you can't even get to have sex. Like it's like no, absolutely not. That's what that patient particularly was feeling. For some people, like I had sex and then immediately it started burning, like, and now I have a UTI. Again, this is the disconnect and like how society and science actually go are polar opposites when it comes to women's health. We know that for an infection to take place, it takes at least 48 hours for an incubation, like 48 to 72 hours. So many people, when they have post-sex UTIs, immediately get symptoms.
Mm-hmm.
That's not an infection. But do you see, like, we know that. We know on a healthcare system that you get a bacteria, like, some like baby sneezes in your nose. You're not immediately going to, like, get a cold right then and there. Yeah, it's going to take a couple of days. And yet, because people chose to not like apply science to women's sexual health,
Yeah.
we just are like, of course you got a UTI immediately after sex, 10 minutes, like so that's the other thing is that, if you're getting symptoms immediately after, it's not a UTI. It's just not. It's like, so what could it be? Oftentimes it's that
Mm-hmm.
hormonally mediated vestibulodynia. It's also a combination of pelvic floor dysfunction because now I have an active sunburn. Now that sunburn is triggered, it can either feel like pain with sex or it can feel like lower urinary tract symptoms that mimic UTIs, and then my pelvic floor is going to tense up because I'm in pain, and then it's going to worsen your symptoms. And so a lot of people also report lower abdominal cramping.
Mm-hmm.
When you have lower abdominal cramping, that's actually pelvic floor dysfunction. That's your pelvic muscles tightening up, and it's actually pulling on the sheath of the muscle. So do you see how there's so much symptom overlap? And so
Yeah.
because there's so much symptom overlap, you have to have a wide toolkit to actually
Mm-hmm.
rule things in and rule things out. But most doctors just have infection or no infection. And I was able to develop a well, it could be this, it could be that, it could be this, it could be that. Let's work through it and
Yeah.
actually figure out what's going on.
Yeah, I think that's much more important for a lot of people who do have pain and they don't know where it's coming from. They've had many different diagnoses often. And if it was caused by taking oral contraception, is the solution just to stop that, or do you actually need to do further treatment?
Yeah, so great question. So it all depends on the severity. For some
Hmm.
people, it's so mild that like that inflammation state is so mild that they stop the OCPs and then their body just heals itself. The human body is miraculous. It can do a lot of things. So it's not uncommon when even just at like a grocery store, if I tell people what I do, they're like, I had chronic vaginal infections for years and then I stopped my OCPs and then it's fine, like
Yeah.
and and I'm like, oh, and then we talk about the science, and then we laugh, and then I say thank you, and then I go home. But so if it's pretty low severity in terms of the inflammation, and you just stop it, yeah, great, amazing for some people. But for most people, the inflammation is moderate to severe enough that even if they stop the OCPs, it won't reverse the inflammation. Like
Hmm.
your body can't necessarily heal it, and that's the also the beauty of it is that we then just give you a topical medication that replenishes the hormones to the tissue and heals the tissue. I call it, I say, I have an analogy and I hate it, and I'm going to get a better one day, but it makes the most sense. Your vulva is a garden. Your garden needs sunlight, nutrients, and water to stay healthy, aka your vulva needs hormones, estrogen, progesterone, and all the things to stay healthy. When you are being stripped, particularly of the testosterone, because you can also get this with estrogen. Essentially, it's all about balance. You can have this
Hmm.
with estrogen, you can have this with testosterone. We just see it way more with testosterone because the medications that we're giving tend to have more anti-testosterone side
Hmm.
effects. Um, and so if you just give the garden exactly what it needs, that garden will come right back. Will come right back to life and will become like healthy. The vulva is one of the coolest structures ever. It has such regenerative properties that no other tissue I've ever seen has. Even in like, if you were 70 years old and your vulva actually started to shrink and go through these chronic inflammation changes, if I start you on low dose vaginal hormones, your vulva will spring right back to life. Like that doesn't happen in any other tissue structure. Like there's so much research that is so ripe and it's so
Hmm.
exciting in the vulva. And because of medical sexism and society and culture, the entire community has just forgotten that it exists and it has science behind it and it has really cool science behind it. And it really matters for your bladder health too.
Are there non-hormonal approaches you can use in that kind of situation?
Okay, so no. Not that because I think hormones get a bad rap, right? They
Hmm.
get such a bad rap. People are so scared of hormones, and yet our bodies are naturally producing hormones at all times. Our bodies are constantly like flooded with hormones. That
Hmm.
is what keeps us youthful. That is what keeps our cells active. That is what keeps our body moving. And because, again, society and culture have villainized hormones, like in men, hormones are celebrated. In women, hormones are villainized. It's
Hmm.
such an interesting, like,
Yeah.
sociologic study. Of, and yet hormones are the key to sustaining the garden, right? And so hormones not only keep the tissue healthy, but it also keeps our ecosystem healthy. So our flora is a actual response of our vaginal flora is an actual response of our hormonal status. When we lose our hormones and our or change our hormones or alter our hormones, it changes our microbiome, which then predisposes us to infection. So I really, really want people to stop being afraid of hormones. Like low dose vaginal hormones, we actually even give it to people with active cancers,
Hmm.
breast cancers, all the things to help them with their vaginal symptoms. So, um, Yeah, I really do think that hormones are truly the key to a lot of the reversal. Is there like moisturizers, like topical agents? Yes. Over the counter? Yes. But that's more fixing a symptom of an
Hmm.
issue than actually getting down to the root cause of the issue. And especially, why not get down to the root cause of the issue when there are cheap, safe, so many studies have shown that it is safe ways to actually solve the problem. So yeah, I want to de-villainize hormones for people. And also with low dose vaginal hormones, it doesn't actually change your bloodstream levels. So it's such a low concentration that all it does is it works in the garden. So that's why I go back to the garden analogy.
Yeah.
If you water your garden, you're not worried about flooding your house. So it's again just acting very locally to the
Yeah.
tissue.
I think some people are not afraid of trying hormones, but have had experiences where they've been sensitive to it. So it's caused, like vaginal estrogen has caused irritation or pain. Do you think that's the estrogen itself or something else in the topical application?
It's the base that it's in. That's actually always the case. And I very much compound my own vaginal hormones. I don't
Hmm.
do compounded systemic hormones, but I do compound my vaginal hormones just because like I have super sensitive skin. I could
Right.
not use any of the commercially available products. So like why would I subject my patients to that? You already have chronic inflammation. I'm going
Exactly.
to make sure that the medication I'm going to give you is as hypoallergenic as possible. So I always ask patients, like, what has worked for you? What base, like, can you do coconut oil? Can you do like olive oil, emu oil? There's
Hmm.
so many things that you can compound things in. So oftentimes, if you're having reactions to a commercially available vaginal estrogen, and I rarely ever prescribe vaginal estrogen. I prescribe a compounded estrogen and testosterone cream. I
Hmm.
always do estrogen or testosterone um, as well because it's a huge part of the equation. So, but even just with vaginal estrogen, I will make a plug. It also saves lives. So vaginal estrogen is the current guideline. It's in
Hmm.
there, it's out there. Vaginal DHEA is also in the guidelines too. And that's I think it's a better product. It's vaginal DHEA is converted to estrogen and testosterone in the vaginal canal. I think that's the optimal product. But
Hmm.
if you're weary or your doctor's weary or not comfortable with vaginal DHEA, any sort of hormone is better than no hormone. So if in a
Right.
perfect world, you'd get a combination of estrogen and testosterone. But if you're in the world and your doctor's like, I'm not ready, I don't feel comfortable, or at any hormone is better than no hormones. And if you're not getting better on vaginal estrogen, then switch over to vaginal DHEA or compounded estradiol and testosterone cream.
Okay, great. Well, this has all been incredibly insightful. And two quick questions for the end. If there are clinicians watching this that would like to learn from you, is that possible? And if there are patients who'd like to schedule an appointment, how can they go about that?
Yeah, so if there are clinicians that want to learn, I built a whole health tech company called VULVAi on how to train yourself and how to teach yourself how to increase your toolbox and your toolkit on being a better diagnostician and being able to support people experiencing vulvovaginal conditions, whether it's chronic pelvic pain, recurrent UTIs, chronic vaginal infections, and also we also run the gamut of female sexual dysfunction and menopause. So essentially, we're filling in the gaps where women's health and vulvar health have failed the
Hmm.
curriculum. So yeah, please reach out on vulvaai.co. So www.vulvai.co. We're currently piloting at different institutions. If you want to bring us in, we'd love to work with you. And then from a patient standpoint, um, uh, also sign up for the waiting list for Vulva AI. We're going to be making patient-facing things. It's going to be in the next year. We're working on
Hmm.
getting funding. So if anyone wants to fund the revolution in women's health, reach out to me directly. We are also always looking for funding in order to get this research disseminated, get this care disseminated.
Yeah,
It's
great.
really, really, really important. And then if you want to actually work with me, I do, if you're in the state of California, Um, you can actually see me in my clinic in LA directly, and you can find that on my website at mariaulocomd.com. But if you are outside of the state of California, I also have virtual educational consultations where I teach you about I hear your story. I come up with a little plan. I talk to you about, okay, diagnostically, this is what are the things that I would recommend asking
Hmm.
for. And we kind of coach you on how to advocate for yourself in the doctor's office, how to get that diagnosis. Because it's, I'm a big believer that a lot of what we're calling chronic diseases aren't chronic, they're just misdiagnosed. And
Hmm.
so to be able to give you that framework of much faster than waiting for our app to fully get out in the world, please reach out and sign up. And you can find all of that on my website.
That's great. And we'll also add the links to the video description so people can find it more easily. Thank you
Amazing.
so much again for joining me and answering all our questions.
Of course.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.